Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast, in which we will continue our exploration of motor neuron disease. In this episode, I will be speaking with Dr. Allan Ropper, co-author of the book titled Reaching Down the Rabbit Hole, and we'll be discussing end-of-life issues around MND. Dr. Allan H. Ropper is professor of neurology at Harvard Medical School and associate editor of the New England Journal of Medicine. He was born in 1950 in New York and received his BA from Cornell University in Ithaca, New York, and his MD from Cornell University Medical College in New York in 1974. Dr. Ropper trained in internal medicine at UCSF Moffitt Hospital and in neurology at Massachusetts General Hospital. His work has been predominantly in the field of neurological intensive care and related disorders such as Guillain-Barré syndrome, stroke, and brain death. He has conducted NIH-sponsored studies of vascular endothelial growth factor, VEGF, for the treatment of diabetic neuropathy and experimental models of chemotherapy-induced neuropathy. He has over 180 publications and is the lead author of the most widely consulted textbook of neurology, Principles of Neurology, which will be coming out in its 12th edition very soon. He is a long-time contributor to several major textbooks of medicine, including Harrison's Principles of Internal Medicine, and he has won numerous awards, including the Raymond Adams Award of the ANA, Lifetime Achievement Award of the AAN, and Distinguished Alumni Award from Cornell Weill Medical School. He was elected an honorary FRCP. Dr. Ropper has received numerous awards for teaching and service. And his book on the life of a neurologist for the general public, which we're talking about today, was a Times of London and BBC Book of the Week. His allied book, How the Brain Lost Its Mind, was published by Avery Penguin Press in 2019. Dr. Ropper, welcome to the Neurology Lounge podcast, and I'm very glad to have you here. I'm very honored. You honored my invitation, and thank you very much.
It's a pleasure to join you. Thank you for inviting me.
Thank you. The usual first question I ask is, why did you write the book? I know it's a co-authored book, but it's kind of what was the inspiration for writing the book?
There were two streams. The first was that I discovered through practice and speaking to patients and even family that people don't know what neurologists do. If you ask them, they say, oh, it's the nerves, as if you were, I don't know, Roderick Glossop from a P.G. Wodehouse story, a noted nerve specialist. They don't really comprehend the scope of it and the difficulty. The second reason, there are three maybe, was that I really think it differs from other fields of medicine, which is why I called it the queen of the medical specialties. It involves not just trying to query the sick organ, which is something that other specialists don't have to do. After all, the liver or the kidney don't speak. You know what the kidneys make, but the brain makes poetry. So it's a different question. But I'll tell you what really precipitated it in the end. I was getting a little bit tired of the romanticization of brain science and the brain, and every publication, the Times of London, the New York Times, everything. Oh, brain this, brain that, and functional imaging. You can tell what people are thinking, and so on and so forth. And I spoke to Oliver Sacks about this several times. Of course, the public had the idea of neurology based on his magnificent stories. And I said, you know what? It's not really like that at all. It's very hard. It's dirty. And the cold, hard truth of neurology is, difficult. So I wanted to de-romanticize it, bring it back to ground. And inadvertently, I wanted to answer the question to younger people, why be a neurologist? Why go into the field? So that's why I wrote the book. There's no one reason.
And I know it's a co-authored book. How did you go about writing it? It's
Brian Burrell is a good friend of mine. He is steeped in medical history, although his background is in mathematics. Um, he wrote a book which I highly recommend called Postcards from the Brain Museum,
Okay.
in which he explored brain museums, going back to Virchow and going right up through the one that's at Harvard, and talked about the history of phrenology, the notions of what kinds of attributes were attributable to the visible characteristics of the brain, how they affected society. So I had read that. We befriended each other. He does a lot of wonderful research, but of course the stories were mine, medical stories. How do we write it? We really sat down and decided on the scope of it together. He joined me on rounds a number of times. We took notes, recordings, interviewed people that you can tell from the book. And we co-wrote most of the material, went over together, edited together. Some of it is predominantly mine, like the motor neuron material that you alluded to. He was very taken with the patients who had mental disorders as a result of brain disease and the ambiguity there, and was interested in what qualifies as a disease as opposed to a disorder if there's nothing to be found in the nervous system. So that's how we wrote it. And that's how we wrote the second book too. And if I could, your invitation is timely because Reaching Down the Rabbit Hole is being reissued. It was popular enough that they're going to reissue it.
Okay.
And we're in the process of writing a epilogue chapter to follow up on all the characters, individuals who are in the book.
Okay, that's interesting. Perfect timing. And I'm assuming then the title "Reaching Down the Rabbit Hole" was that your idea or
Yeah.
his? Okay.
Well, I think we came up with it together.
Okay.
Because we have the Alice in Wonderland motif, as a backbone, the Queen saying it's a peculiar sort of memory that only works backwards. And we thought that was apt. I don't remember if the publishers came up with it or something like that, but no, we had something like that in mind. Now, the original title, which
Okay.
I was very much in favor of, but the publishers and people we spoke to found it too opaque, was Do Helicopters Eat Their Young? Which is,
Okay.
one of the inane questions that you can ask, like, is it warmer in the summer or the South?
Yeah.
To see if people really do comprehend or if they're giving you automatic answers. But it was felt to be too obscure, so we had to let go of it.
And it talks about each of your patients or each neurology patient having fallen into this hole. And it's the duty of the neurologist to kind of get the patient out of that hole.
Yes, or at least try, which is, of course, with motor neuron disease, the skill set is very special. It's not just knowledge.
Yeah.
That's why I chose 2 chapters to emphasize that. Plus, those were interesting stories.
Yeah, absolutely. And that's kind of, well, it's a great book, and it's a very shame that I have to focus on the MND part, but there were 2 excellent chapters. And why you gave MND this privilege. I was going to ask why MND? Why not something else?
Well, one could make a case that almost any serious neurologic disorder deserves the support and ongoing attention of the physician. That goes without saying. But I thought because the outcome of motor neuron disease has such certitude, you can circumscribe what's going to happen. You can help the patient anticipate it. And most of all, perhaps allow the patient the latitude to make decisions at each of the junctures that you know from experience will occur. Whereas cancer, well, certainly in the modern era, could go in a lot of different ways. Almost any disorder can, infectious diseases, so on. So multiple sclerosis, perhaps more so. Here, we have a roadmap. The temporal sequence or the duration may not be precisely known, but the facts are very well known. respiratory failure, weakness, dependence, and so on. And I thought that my observation had been that the general physicians, the physical medicine people, psychological support people sort of abdicated their roles here, and it fell to the neurologist. And quite often, of course, the neurologist didn't have the personal latitude to do what I thought might be best. There's no one best, but it's the commitment level that's required for those patients. Patients with epilepsy may require frequent encounters, Parkinson's, frequent encounters to trim the medicines, alter the deep brain stimulation, change the immunomodulating treatment, all that kind of stuff. But that's actually typically delegated around here to, let's say, ancillary care providers, because they're so repetitive and mundane. But what are you going to tell a patient with ALS? What's your value added? So that was one motivation, but it had to do perhaps more than that with the interest in the stories.
And well, you titled End Game, which is quite reflective of ALS, isn't it? But the first chapter on MND talked about Louise Nagel.
Yes.
The woman who had breathing difficulty climbing stairs for 3 months and ended up with pulmonary and cardiac specialist, and kind of had this long run around before she finally ended up with a diagnosis. Why do we have this case where patients with MND end up usually going round in circles before they end up with a neurologist?
I think it's similar to what happens when Parkinson patients manifest mostly non-motor symptoms early on. They go to a lot of different specialists. I've had this experience, and it's not a criticism of our colleagues. I would be interested in your experience here, but some of these motor neuron disease patients, fair proportion, end up seeing orthopedic doctors. I've had cervical spondylosis operated on unnecessarily because of lack of recognition. Breathlessness or dyspnea with exertion attributed to anxiety or some vague pulmonary process, so on and so forth. And even within neurology, of course, the diagnosis is not always that clear, certainly early on. I mean, if you wait it out, it becomes clearer. And there's differential. So I don't know why. I think that's a longer discussion. It would be a digression into how people are trained these days and how ultra specialization has limited our ability to think outside what we usually do.
And I think it might hark back to what you said at the beginning. Most people don't know what neurologists do. So when there's a problem, the orthopedics kind of come first before anybody thinks.
Certainly.
A neurological problem. But yet, as soon as you saw, you picked up on what you said was a slight palpitation between the thumb and first finger. And this was even before you really sat down to talk to her. You referred to this as the butterfly of doom.
Yeah. It always makes my stomach sink. It's like the split hand. What she had basically was the split hand of ALS. And, I mean, things imitate that, but it certainly makes you think that you're headed in that direction.
In the overall context, of course. But there are quite a few benign causes of fasciculations. Is the location the key thing here? It wasn't in the...
No, that's a common location for maybe a cervical radiculopathy too, or benign fasciculations. It was just that hearing somebody who had breathing difficulty and seeing that aligns in a way that, is you at least know where you're going to look.
And I guess, next question is probably, you probably have a heart sink moment, isn't it, when you think this could be MND? And
I do.
Yeah, and you said for 2 days you vacillated before you had the conversation.
Yeah.
The wait?
Well, I think it's useful to wait. I sometimes will hint at something having to do with degeneration of the nerves, so that people are aware that it's not something that can be taken lightly. And then how to introduce the diagnosis of motor neuron disease is stylistic. It's not, there's no one way. Every individual develops their own approach. But it's a tough conversation. Sometimes it's had in pieces over time, particularly if you're waiting for more evidence. You want a second EMG or whatever, whatever it is. You're waiting for a protein immunoelectrophoresis to make sure you're not looking at an anti-GM1 or something that at least could simulate it. So you're not obliged to be forthright immediately. And I don't think that that's deluding the patient. I think that's figuring out not only the case, but who this patient is, how you can approach them most appropriately, who else needs to be in the room. And once you mention ALS, at least in the United States, there's enough secular knowledge about it that people will, am I going to die? I mean, you have to anticipate the subsequent questions. How are you going to answer those? That's a very complicated conversation, as you can imagine.
Then in the internet age, I mean, a lot of people read about these things. I find it helpful to ask them what they think it is. And I suppose it's kind of a shortcut to try to avoid breaking the name.
The news.
Yeah, but breaking the name, because if they
bring the name, I see.
They bring it.
What do you think it is, right? I could imagine somebody coming in and saying, I think it's multifocal motor conduction block.
That's true in this day and age.
I don't think so. No, that's certainly, I will do that with Parkinson patients because I know that they know. Yeah. It's a little less subtle and it's more ubiquitous. Here, I don't know. I think it depends in part on the characterological traits of the individual patient, who they're with. Is it a spouse? Is it a child? How old they are? Do they have familiarity with neurologic disease? But I think the neurologist is in the best situation to manage this. The question is, do you have the internal fortitude to manage it and manage it over time? Because the other patient lived for 23 years.
Yeah.
With motor neuron disease.
And yeah, so that's George Calomiris.
Calomiris, yeah.
Yeah.
It's not his real name, but yeah.
Okay. Yeah. And of him, you said your personal judgment of him again vacillated between bravery and selfishness. He went on supported ventilation, isn't it? And
yes.
Alive. And I guess you're not, from that statement, you're not quite sure that was the best way somebody with MND should go, or were you reserving judgment as to?
I was reserving judgment, and I can tell you now, but I'm not going to disclose too much because he will take up a fair portion of the new chapter in the reissued book.
Okay.
In retrospect, I saw exactly why he did what he did, and I did not view it as selfish.
Okay. Okay, we would not dig too much into that. But I know.
Well, I got to know him better over. I mean, it's almost like a long friendship. I was at his house, spoke to his wife, his daughter. There were a lot of stories in between, things that happened. And I viewed it, the bravery part goes without saying because you have to have a lot of guts to stay at home with a ventilator and a feeding tube and attendance. Yeah. But he did it for him for the right reasons, and it so happened that it paid off for his family. So that it was not selfish.
Okay, we have to wait for the revision then to see.
Yes, you do, and you have to purchase it.
How that played out. But with Nigel, she went into the terminal stages.
Yeah.
Said she could feel everything and move almost nothing. Yeah. Eventually coming an eyelash away from being completely locked in. I think it's correct. Probably that picture of the terminal stages of MND that's quite distressing, I suppose, for for most people and their families.
Yes.
And in many places, this question of ending it, unlike Calomiris, who carried on, the question of ending it comes in, and whether to have euthanasia or not. Is that an issue that you face in your practice?
Yes, absolutely. Less so than people like Bob Brown, for example, who have a predominantly motor neuron disease practice. I mean, my career started in critical care neurology, and I made most of the papers that I published as a result of that. But subsequently, I became just a general office neurologist with panoply of cases, but often more difficult, either personally more difficult or clinically more difficult. So that ended up being concentrated in Parkinson's, immune neuropathies, and motor neuron disease. And there are experts in Boston in motor neuron disease who are far more knowledgeable than I am. But I ended up seeing a lot of those patients nevertheless because they had heard that I was willing to engage with them on an ongoing basis and was flexible and so on. Not that the other physicians were not, but these things just take on a life of their own.
Yeah. And I know, I can't remember whether it was in this book you talked about your involvement with the famous celebrity with Parkinson's disease and deep brain stimulation, but we probably
that actually was thalamotomy with that
yeah,
individual.
yeah.
Yeah, no DPS.
Sorry,
Yeah,
thalamotomy at that
yeah,
time. Yeah.
right. It was a very interesting because in querying Mr. Fox, he now agrees that that was absolutely the right thing to do at the time, that he was not interested in DBS. I think that's all in the book, maybe, but I I don't think he would deny that, which is very interesting. So, everyone's different. You know as well as I and all the colleagues who listen will know, so much depends on how things are presented. And the patient is looking for guidance. I appreciate acutely the shared decision-making trope of the modern era, but I think it's a little misguided at times.
Expecting to share decision making with somebody who doesn't know as much, I suppose.
Not just as much, but I think to correct me if I'm wrong, patients are coming to the physician for that kind of guidance, not to be asked, what do you want to do? Now, partly that's a generational thing. I understand, control and so on. But I've seen a lot of bad decisions made.
Yeah.
Now, they're not bad from the patient's point of view because you're entitled to do whatever you wish. But from a strictly medical point of view, bad decisions. And yet, there's autonomy. I don't deny that.
I think it's I think the fear of paternalism in medicine, which is pushing into the other end.
I like to view it as avuncular, not paternalistic.
Okay, that's a good one. Okay, that kind of brings us again to the issue of the personality of people with motor neuron disease.
Oh boy.
Yeah, and you noted that MND predominantly affects nice people, and that immunizes neurologists. I think that was a good job. Do you think the pleasant nature is a consequence of the motor neuron disease, or do you think it's a kind of pre-morbid thing that is linked to a vulnerability to developing motor neuron disease?
Well, first the question is it a valid connection? Which, how can you say? You can't really. I'm reflecting on the people I encountered. And of course, I encountered them around the time the diagnosis is made or afterwards. So one could propose that it's a reaction to or the way in which people deal with it. But I find that to be paradoxical. I mean, if you heard you had motor neuron disease, I don't mean you, an individual, you'd freak out, especially if you're a neurologist. And by the way, I cannot tell you how many neurologists have come to my office because they had a fasciculation and were sure they had motor neuron disease. And to talk them off the ledge takes like an hour and a half because they know too much.
That's true.
And they weren't all nice guys. So maybe that was maybe that was an indicator. I don't know the answer to that.
Well,
Yeah. Go
I
ahead.
used to sit in with a motor neuron disease MND meeting where we discuss patients with palliative care. They seem to have a different view of the personality of people with MND, which again is anecdotal, but they've maybe as the disease progresses, I don't know, they seem to think maybe the opposite of nice rather than nice. But
Well, they get demanding because they require help for every little thing, to move a finger, to get a limb better, to change a television channel. And I think that is wearing on caregivers and even palliative care. But, I mean, that's a throwaway idea. And frankly, I heard that connection in medical school
yeah,
from Fred Plum,
crept.
uh, as just a casual
Mm.
comment. I mean, but it went away. I don't know if you're aware, you're younger than I. We were given to believe, and I'm not joking here, by some very authoritative people that only individuals with a rigid personality got Parkinson's disease.
Okay, no, I haven't heard that. It's probably went
No,
out.
no, that was around for a long time.
Okay.
And I remember looking around at my classmates and going, what are they serious? But you have to remember it was a post-Freudian world, and meaning of personality was imputed for everything. So, I don't know.
Yeah, I mean, one that comes to mind is I was reading a book on autism and this link between the refrigerator mothers giving birth to children with autism. It's
Schizophrenic. The refrigerator mother
yeah,
one
yeah.
was for schizophrenia, and that was tragic. I was around for that. That was promoted by a man named Lindemann,
Okay,
a psychoanalyst in Boston. That's a very long story. That I think I have part of that story in my second book
okay.
about the grip that psychoanalysis had and what it did to neurology.
Well, okay.
So,
Um,
yeah.
it, yeah, there's big. Well, we end up in a very deep hole with this discussion. I'll go to the next bit. Your portrait of people with MND was you talked about their perseverance, their resilience, um, but also annoyance and frustration. Do they teach you something? I mean, in the way they face their illness.
You know, I I don't believe, let me put it this way. I don't believe people change much.
Okay.
That means me and the patient. Circumstances change
Mm.
and they bring things out in people. So do they teach? They perhaps teach me to be a little bit more compassionate, but I don't think I'm learning any life lessons from it
Okay.
because it's impossible for any of us to truly contemplate putting ourselves in the shoes of somebody with uh, a serious and fatal illness. We can make pronouncements about how we would like to be treated if, for example, we had some kind of brain damage, cardiac arrest, or a head trauma, and relate that to people. But that's an emergent property of what we've thought about our whole lives, our exposure, our upbringing, our situations, our personal situations.
Hmm.
So, and I don't think that anything I've seen from patients in that regard informs me. What I've seen with regard to the overuse of medical technology informs me, but that's not a property of the patient.
No, no. Okay. I always wondered whether we learn things like that.
I'm sure there are people who do. Daniela Lamas, who
Yeah.
was a fellow at the New England Journal, writes very nice brief articles in the New York Times, and they will often end with her reflections on what she feels she has learned. I mean, and very thoughtful.
Hmm. That's interesting. Okay. Going on to another, the book was too big, and I feel guilty focusing on MND. I thought I would just bring one other bit, which is not MND, from your book. Is it your views on functional neurological disorders? And you title that, the subtitle of the chapter on that was The Politically Incorrect Guide to Malingering, Shaming, and Hysteria. Were you trying to convey kind of a counter view of what of FND as a neurological illness. Let me put it that way.
I don't think it's a neurological illness. look, I grew up in a circumstance where my father would say, get over it. But I recognize that's very unkind. I don't do that.
Okay.
I'm far more delicate. I'm far more understanding. And that's why I put in, I'm not going to name the person, but the Irish approach to FND comes verbatim from a colleague of mine in Ireland. And it's the opposite of the American approach.
Yeah.
And I think that John Stone in the UK sort of hits a middle ground by saying it's neurological. The brain is doing it. There's only one brain. Why don't we view it from that point of view? The mechanistic aspects are different. I have a little bit of a leftover, generational thing, which is not to say that the patient's to blame by any means.
Okay.
And quite the opposite. In fact, when Ray Adams told me, a lot of these cases, not all,
Yes.
stem from a dissociative state related to childhood sexual abuse. I said, are you crazy? I said to myself, that's nutty. Well, it ends up that a proportion are. So these are individuals who are in need of assistance, without a doubt. The question is how to get them out of that rabbit hole and get them functional again to the best extent you can. And I can tell you some of the most bizarre things that were tried. Miller Fisher, when I was a resident, had a young man come in, a college student, who walked in a lopsided fashion. His right side was dipped down, as if he had a dystonia or something. In fact, he was diagnosed as dystonia. And we all then looked at him, examined him. It was very clear that it was a functional disorder, at that time still called hysteria. Fisher took 2 big boxes of microscope slides, 100 slides each, put them in his hands, and had him walk around the hall for an hour, 3 times a day with them. And every day he would come by and take 3 or 4 slides out of the box on the side that was limping down and say, see, now it's lighter. Now you're being straightened up. And by the time 10 days went by, it was gone. And he said, who cares what the psychodynamics are? We need to find ways to get them out of it. He did not confront them with it. He didn't use phrases equivalent to it's in your mind or it's in your head. But I also wonder whether psychiatrists are the best specialists to contend with this. Some are outstanding at it, some of my colleagues. But the fashions go in and out with FND.
My feeling is I don't think maybe the new generation, but I don't think people who are trained in functional disorders were kind of taught to treat organic disease.
That's true.
But that's, I suppose, it's changing.
By the way, one of the most refined skills of a clinical neurologist is to identify what can and what cannot happen in the nervous system. There's certain things that just can't happen because of the way the system is wired. And those are basically FND. And that's in the remit of neurologists for the most part.
And I suppose the bit about hysteria takes us to your other book, which is another field to talk about, which with regards to Charcot's, again, a co-authored book, wasn't it?
It's How the Brain Lost Its Mind. The original title was Sex, Syphilis, and Psychoanalysis. But again, the publishers think that it would be off-putting. But that's what it's about. It's about Charcot, Freud, a lot of FND, and so I was one of the last people, not personally, but individuals who are contemporary with me, to actually deal with neurosyphilis. We had a Louis clinic at the Mass General Hospital, and the resident's job was to go there every Tuesday morning. They'd line up all of these syphilitics, and you had to do spinal taps on them to see what was happening to their inflammatory response as they were being treated. It was an incredible experience because you saw TABs, general paresis, meningovascular syphilis, stroke, blindness, deafness,
Mhm.
vestibular problems, and stuff that isn't even listed. And I thought, oh my God, this is so rich. And then, of course, it faded away. Now it's coming back. And it's coming back quicker. There's neurosyphilis again, but it's occurring in year 4 to 6 instead of year 7 to 15, which is really interesting. I don't know if you,
Unrelated to HIV or unrelated.
not all, but maybe. It's something along the lines of what's happened to rheumatic fever. You
Okay.
know, those lines of strep, the hemolytic strep are still around, but rheumatic fever is not.
Yeah.
So something's happened. Nevertheless, I always wanted to write about those experiences. And then I wrote this review article, which some people might find helpful, although there's a error in there, which was corrected, um, on neurosyphilis in the New England Journal of Medicine about 2, 3 years ago, because it's an amazing disorder. And if you really want to understand what happened between neurology and psychiatry, that's still the place to look.
Okay. I mean, that's the whole, maybe I'll, maybe I'll bring you back for another session on that.
Gladly.
Okay. I mean, I have to mention something else, which is probably what brought me up to doing a podcast, was a paper you co-authored some way back on how neurologists think, a cognitive psychology perspective on misdiagnosis. I was so impressed by that. Because at the time, I just made a couple of boo-boos and I was wondering how on earth did I get it wrong? And that paper was very timely for me.
Oh, I'm glad.
I presented at a journal club, and everybody was so impressed with it. Was the idea of making right diagnosis and kind of patient safety at the back of your mind when you wrote this book? Is that kind of one of the things how we can easily?
No, not really. No,
Yeah,
no. I mean, that, of course, is a popular thing and it's a very important, but no, I mean, we wanted to understand our own mistakes, but frankly, the biggest uh, lesson from it was that we thought Marty Samuels, who unfortunately recently passed away, thought that it would be important for younger neurologists to know that we made errors, some galactic errors, which I'll acknowledge. And I started giving a series of lectures about this. When I joined the Brigham, Marty was impressed. So we then, looked into the Kahneman and Tversky thinking fast and thinking slow idea of how are these cognitive errors made. But actually, I heard this idea first, should be credited, from a marvelous individual named Roberto Heros, Heros, who was my neurosurgical chief resident when I was a neurology resident at the Mass General. We had to do 3 months minimum in neurosurgery. Taking out subdurals, caring for the patients was fabulous. And he said, we're all hiding our errors. It's a terrible thing. And he gave a talk about his own errors, about which he was brutally honest. And then I just stole it and made it into neurology. But when I actually accumulated the number of errors I made, I was stunned.
well,
Some quite consequential.
yeah. And well, it's said that we learn the best from our mistakes, I suppose.
We do. No, I mean, I think that's probably true, but the price you pay for making a mistake, you take it out on yourself. I think that, again, is a personality trait. I know people who could walk away from them. I've had a lot of trouble doing that.
Yeah, I think surgeons probably do better at that than physicians, I
I
suppose,
think they have to come to grips with it, yes.
quickly. Yeah. Okay. Are there any other lessons you kind of want readers to take away from the book? Any specific?
Well, from the book, look, neurologists are the only ones who are in a position to truly understand what the brain produces, right? There's so many things. There is no animal model of aphasia. All the behavioral disturbances are very faint surrogates for what people are trying to do in animals or in other experimental models. The mental models are interesting, but even the most knowledgeable people in psychiatry and psychoneurology do not believe that the mental workings of the brain map onto the brain. There's some emergent property, not magical or religious, but something having to do with temporal sequencing and connections that are unfathomable. Maybe Michael Fox's work on connectomes and stuff like that will expose more and more. So what I'd like them to take away is that there is a future in academic neurology that applies itself to the phenomenology, that it's not dead.
Okay.
And that we miss things every day that come by at the bedside, in the office, consultations with colleagues. We let them go because we've become so operational, transactional. Let's do the stroke scale and just decide if you need alteplase or whatever. You could teach a monkey that. You don't need a neurologist for that. So what is it we're doing here as clinicians? Increasingly neuroscience, which has a completely different vocabulary than we have, and the well-educated neurologist needs to know what's going on in neuroscience. But they don't do what we do, and we don't do what they do, and we shouldn't mistake the two. And yet there are no openings unless we see them first.
That's profound. I feel another book coming out from that concept. Okay, just coming down to MND. What do you think the immediate and long-term futures hold? It's
Robert Brown, who's now at UMass, was at Mass General for a long time, a very close friend of mine. He and I discussed this. In fact, I was speaking to him about 10 days ago. So far, it's somewhat discouraging, as you know. I am persuaded that the multitude of genes that are being discovered, variants in genes, that influence sporadic ALS emergence, and the genes that are connected to heritofamilial ALS are very close, I know people say this all the time, to disclosing something fundamental about the biology of ALS that will be actionable. And you know that people are nibbling around the edges with some drugs that do this and do that, mitochondria. Of course, there's that unfortunate failed drug. The New England Journal published the phase 2. We recognize it could fail. So that could be huge, right? The other thing, and this is from Bob, it's not my original idea at all. Quite frankly, I was ignorant of it, is that even 10 years ago, if people had spoken about inflammatory processes in motor neuron disease, you wouldn't have known what they were talking about. But it's getting pretty clear that either as a primary or secondary phenomenon, microglia and other other inflammatory, call them broadly inflammatory, and immune processes are somehow buried in here. And of course, some of those variants that I just alluded to influence those pathways. So that's blown open something completely new and could bend the curve. Maybe not cure, but I mean, look what people are willing to accept for Alzheimer's disease, you know, a 3-point difference on a 80-point scale or 18-point scale or something, CDR S sum of boxes. So I'm one would never have conceived that there would be an advance, but I think there will be.
That's interesting.
You should, if you're interested in motor neuron disease, you might want to think having a podcast with Bob Brown. The man is brilliant and is completely committed. Robert Brown at University of Massachusetts in Worcester, just stepped down as chairman. I mean, he's first of all, I'm in a great admiration of him on many counts. Wonderful individual.
Okay.
But he knows this field. He's very conservative. He has some very interesting views on TDP-43 ALS and non-TDP-43, which if you go to the meetings, that's all they talk about now. Anyway, just a thought. So, but you're probably asking the wrong person. I'm not, this isn't my thing.
Yeah.
I'm just an observer.
Well, sometimes it's better seen from a distance than when you're right in there. Well, I have to do a bit of more of reading, I think, before I approach him. It's the complex edge of of ALS. Okay, last question. Any three books you can recommend, either on the brain or on this theme?
Oh, I don't, well, I read mainly mysteries
Okay.
and nonfiction and humor, books on the brain. Um, I've read so many. There are none that really stand out to me. Each one has an angle. I mean, look, Damasio's book, Descartes' Error, is a very interesting approach to what is memory. Books like that I like that are iconoclastic. I don't agree entirely, but they open up a new view. There's a lot of junk science in the popular brain space, as you know, not pseudoscience, junk science.
Yep.
The difference. Kuhn made a distinction between the two.
Hmm.
So there isn't a lot out there. I'll tell you another thing. I think that fiction sometimes transmits insights better than discursive nonfiction. Mark Twain said, he said the difference between fiction and nonfiction is that fiction has to be completely believable. So really good fiction writers. So no, I mean, they would come to mind if I walked in back of me, you see a bookshelf, some of the books are there. Read. Neurologists suffer from not having any recreation. I'm a strong believer that medical schools should obligate neurologists to play golf every Wednesday.
Yeah, that's an
That
expensive.
it would cure burnout.
Yeah, there's a
I
big.
don't know. My family doctor, when I was a child, my mother knew not to call him on Wednesday because he was playing golf.
Okay.
He was one of the most best adjusted people I ever met. Plus, he worked 24 hours a day, 7 days a week. So, if he wasn't going to get burned out, I don't know who was. He, of course, delivered babies in those days and so on, but that's a different story. No, I think we need to talk about what's wrong right now. What has gone wrong? The doctors are not happy. The patients are not happy.
Yes.
The institutions are not happy. And society, as judged by government, is not happy. Why are we allowing this to happen? That's for next time. Stand by.
That's most likely. I'm going to send you another invitation sometime later. Dr. Ropper, thank you very much for participating in this episode of the Neurology Lounge podcast. It's been an honor, and I'm very grateful. And to my audience, thank you so much for listening. Or if you were watching, thanks for watching. If you found it enlightening, you may consider subscribing to my neurology database called NeuroChecklist. And I've also published a smaller book than Dr. Ropper's called Surfing the Brain. You might want to get that as well.
I endorse it.
And want to subscribe to the iTunes, Spotify, YouTube channels to make sure you don't miss the next episode of the podcast. Thank you very much. Dr. Ropper, thank you very much. I really appreciate your time.
Thank you for inviting me. I hope people might find the reissue of Reaching Down the Rabbit Hole interesting. Take care of yourself. You're doing something wonderful.
Thank you very much. Have a nice evening.
Bye-bye.